all of you all. So this is a hands-on training for the workshop. So when we say hands-on training, is that like we have the doctors, and when we walk into a critical care, the round goes very fast, and what normally happens is doctor just gives prescription orders. Patient on enteral nutrition feed, so much volume per hour, and that's it. So this is part A. Part B, who does the feed planning is the dietitian. And for critical care, it has to be a special experienced dietitian because it cannot be worked with just as a freshers. And now you heard so much since morning about the critical care setting. We need to understand so many criticalities of the patient. So what exactly goes in the planning? How does the dietitian plan? And who follows it? Because there are nurses. We have to join the dots. Critical care. The problem in any functioning is that we are not able to join the dots. Individually, we do our work. As students, you read about critical care nutrition, but a typical patient will never come with one critical care complication. There are complications. So that's why in any critical care, it's a multidisciplinary team which is the most important. If we do not have multidisciplinary team, at least we should have knowledge, and that is the very reason we have hands-on workshop on the enteral nutrition. So to get started, I invite Roma to take it further. May jot down your notes and also be prepared with the gadgets. We have kept lot of gadgets and what all the requirements are for the enteral nutrition.
Yeah, so as ma'am has already told you, briefed you about what this workshop is, hands-on workshop on enteral nutrition. So we have been hearing about enteral nutrition since morning in every debate. But what is enteral nutrition? So we have been hearing enteral nutrition is important in critical care, when to start, how to start, what is the right time, how much to give. So first we start with what is enteral nutrition basically to understand. So definition goes as, it is the system of providing nutrition directly into the GI tract by passing the oral cavity. Now it can include the use of liquid supplements or blenderized kitchen feeds, delivery by use of a tube or by surgically making a hole into the GI tract. EN is used in subacute, rehabilitation, long-term care and home setting also. Next please. Now if the patient is walked in the hospital and in the ICU setting, we just blindly start EN. We need to see the indicators for starting an EN enteral nutrition in the patient. So there are two basic indications. First is the patient should be having a functional GI tract with absorptive capacity. The second is whether the patient is able to eat or not. Is there an inability to eat food orally, either completely or partially? So if we see inability to eat, that could be because of neurological defect where the patient is not able to eat at all. Okay, so that could be neurological defect like dysphagia, there could be trauma, there could be brain injury, there could be if the patient is on the ventilator or in the comatose state. Second is inability to eat adequately. So if the patient is eating but the goals are not met, the goals for nutrition, the calorie and protein requirement are not met by the oral intake, then we start the enteral nutrition support. These can be in the conditions where the patient is in hypermetabolic state, impaired intake after orophageal surgery, anorexia or failure to thrive. Third is impaired digestion, absorption or metabolism. So there are certain clinical conditions where the patient's digestive system is not intact, the absorption of nutrients that we are giving through oral or is not happening, or the metabolism disturbances is there. For example, in conditions like inborn error of metabolism, Crohn's disease, short bowel syndromes or acute pancreatitis or chronic pancreatitis. Next. Now there is a process, there is a whole process of initiating an enteral nutrition. So that process include first, as I said, assessing, looking for the indicators that this patient is the right patient to start, or this is the right time to start the enteral nutrition. So first we look into the indicator, then we evaluate the patient, or what we do is we screen the patient and assess the patient. Assess the patient keeping in mind or collecting the data of the patient history, medical condition, biochemical parameters and anthropometric measurements or any other test done. On the basis of assessment done, we prescribe an enteral nutrition regime. We review the order, then the order as per the regime, the enteral nutrition supplementation is procured, prepared, labeled properly. It is very important that it is labeled, it is prepared in a hygienically way and then labeled properly so that it is going to the right patient, then dispensed to the ward or to the ICU at the patient side. Then administration of EN regime, whatever is planned, it is administered to patient, and then monitoring and reassessing the patient is very important. So it's not just we have planned an enteral nutrition formulation and entire day course and we have just made the feed and send it to the ICU or asked for the administration, but we do have to monitor whether there have been interruptions while following the regime or not. So that for that monitoring on a daily basis is important and reassessing the patient again whether there is a need of change in the enteral nutrition regime that was already planned for the patient. Next. Now there are different enteral excess. So how do we initiate an enteral nutrition supplementation if the patient is not taking orally or sufficiently eating orally? So first is nasogastric. So as the name suggests, naso and gastric. So the tube, it's a tube that is used which is put via nose into the stomach. Naso, nose, and gastric is stomach. The other is nasoduodenal and nasojejunal, which is also called as post pyloric feeding, where the tube is put from the rice tube is put from the nose into the duodenum or the jejunum. The third one is gastrotomy options, that is percutaneous endoscopic gastrotomy. So now this is a little invasive procedure where a hole is made directly into the abdomen and the catheter or the tube is placed and the feeds are given. The fourth one is jejunostomy option, which is PEJ, percutaneous endoscopic jejunostomy, where the feed is given directly into the jejunum by making a hole in the abdomen again. Now when we talk about nasogastric feeding, the placement of the tube is directly done without any invasive procedure. But to confirm the placement of the tube, that whether the tube is placed at the right place or not, there are two procedures which are done. First, we can run an X-ray, the doctor runs an X-ray to see if the tube is at the right place. The second is, at times the doctor pulls out gastric juice via syringe and tests for the pH level. If the pH is same as that of stomach, that means the tube is placed in the right place. Similarly for nasoduodenal and nasojejunal, the tube is put directly but with the help of endoscope. So the endoscope is a tube with the camera on the tip, which is which helps to actually point out the place where the tube is supposed to be placed. These both, whether it is nasogastric or nasoenteric, what we call is, which is further divided into duodenal and jejunal, these both feeds are for shorter term, for shorter use. So if the patient is only for, or you have to give enteral nutrition support via tube feeding for a shorter period of time, these two are the ideal one. Wherein gastrotomy and jejunostomy is a little invasive procedure, and it is done either radiologically, surgically, or with the help of an endoscope. But the delivery of feed is quite easy, it is easily manageable. So when we talk about tube feeding, let me show you what it, a bag looks like. This is an RT bag which is used, a feeding bag which is used for enteral nutrition support, feeding. So which has a tube which is attached to the rice tube, which is put from the nose into the stomach. Now the size of this tube differs. In pediatric it is different. In elderly we usually use 14 or 16 French size tube. Now these tubes, and there is a syringe also which is used while feeding. So when we talk about tube, this is made of basically three material. One is polyvinyl chloride, which was used earlier, nowadays hardly used because of its shortcoming, because it gets stiffened when exposed to gastric juices, and so it becomes very irritating for the patient, and it also damages the mucosa inside. So it also requires frequent replacement, so it's not very much used now. It was replaced by another material which is silicone, which is more softer and it has a tendency to stretch properly. Then the third one is polyurethane, which is commonly used these days because it is more, the strength is better. It has a thinner wall. So the tube has a thinner wall which gives it a better diameter inside. The diameter increases inside. So even with the small tube, the flow of the feed becomes very easy. Then the next is characteristics of enteral formulas. I would like Rajeshwari ma'am to talk about this.
Till Rajeshri comes and seeing the tubes, we also seeing that once we have kept the presentation initially so that we know the theory, and then we will be actually going and looking at the tubes. We try to see and understand what the formulas are, because this is what hands-on training. In clinical setup, like as I said in the beginning, the doctor prescribes the dietitian plan, but actually the monitoring, the delivery of the feed is the crucial and the most important. Right? Like we want something and we tell our tailor to make, but the tailor who is going to make is the most important. So one who's going to make the feed is the most important. So before the feed is made, let's understand what the characteristics of feed are.
So basically the enteral formulas are classified into two types, that is kitchen-based feeds and the commercial formulas. So kitchen-based feeds are actually mechanically blenderized feeds. Like for example, you must have seen in your hospital like mashed khichdi or otherwise vegetable soups or buttermilk. Now the disadvantages of these this kitchen-based feeds are that there is under-delivery of nutrients. Secondly, that is the viscosity is high, and thirdly, this the day-to-day variation of nutrients and osmolality. Next, we move on to the commercial formulas which are prepared by the pharma industry. These are either in powder or liquid form, and they are broadly classified into this polymeric, oligomeric, and monomeric formulas. The polymeric are again subdivided into the standard, the high protein, and the high energy formulas. The standard formulas have the RDA values same, the macronutrient and the micronutrient composition of these standard formulas are same as that of for a normal healthy population. So the carbohydrate consists mostly of maltodextrins or sucrose. The protein is usually the egg albumin or the soy protein. In case of plant protein, it is pea protein, and the fat consists mostly of the vegetable oil and the MCT. Next, we move on to the high protein formulas. So the standard formulas are basically used for patients who are having a normal the GI is functioning properly. So in adults, and they are also used in case of children. Next is high protein formulas. That is, here the high protein formulas are mostly used for patients who require a little higher amount of energy, higher amount of protein. That is, those who are markedly catabolic, and those who are having severe malnutrition. So in those cases, these high protein formulas are used. Next is the energy dense formulas. So these energy dense formulas are mostly used in cases where there is fluid restriction. Patient has come with fluid restriction, and patient is having mostly electrolyte imbalance, and this is mostly seen in cardiac and renal cases. Okay, so you get these are energy dense formulas which can supply this energy up to 2 kilocalories per ml. And this next we move on to this. Next we move on to oligomeric formulas. The oligomeric formulas are partially hydrolyzed formulas, that is pre-digested formulas. So they mostly contain the dipeptides or tripeptides, and they are in which conditions they are used. So the thing is, like, when the standard formulas are not working, the patient is not able to tolerate the standard formulas, that is the time when the oligomeric formula is used. Secondly, when the feed is being directed to the jejunum, that is the case when you cannot use the standard formula, you have to use the oligomeric formula. Thirdly, you can also use in patients with this bowel function disorders. In that case also you can use. Next we move on to monomeric formulas. That is, these monomeric formulas are also known as elemental formulas. They contain free amino acids, they contain a small amount of MCT, and they also contain glucose. Mainly and absorption. They are also used in cases where severe pancreatitis that case also monomeric formulas are used. Next, we move on to disease-specific renal formulas. I would also like to say that monomeric formulas are also used in cases where there is severe allergy of dietary protein. So in that cases also monomeric formulas are used. But straight away we cannot jump to a monomeric formula. See, there is a vast market of formulas, but the thing is, we have to choose our formula carefully. So we can't straight away jump to monomeric formula. Then there is a disease specific formula, that is in these formulas the macro and the micronutrient composition is adapted to the specific disease or the medical condition. So the examples of these are like renal formulas, then liver based formulas, then neuro formulas and diabetes formulas. So next we also have the this immune enhancing formulas. You will be seeing that also. So these immune enhancing formulas, they contain nucleotides, then omega fats and arginine, glutamine. So all this is present in that. And immune enhancing formulas are mainly used in patients with cancer because they have to undergo this chemotherapy, radiotherapy and all. And they are also used in patients who are posted for surgery. So it can be used pre-surgery also. It can be used post-surgery also. Next. So when you're selecting a formula, there are certain factors to be considered. That is the functional status of the GI tract, then the physical characteristics of the formula. That is the osmolality, the fiber content, the caloric density and the viscosity. So if your patient needs a low fiber formula, you will choose a low fiber formula. But if your patient wants a high fiber content, then you will go in for this formula with also the macronutrient ratio, also and the absorption capacity and the specific metabolic needs of the patient and contribution of the feeding to fluid and electrolyte needs on restriction. So suppose if you have a renal patient with you, so what matters, like sodium, potassium, all that matters. So you will select a formula like suppose this potassium is safe and this sodium is also comparatively high. So then you will choose less of sodium. You will not, okay. And also cost effectiveness, that also matters. That is also a major.
You can visualize also over there, and please remember, please ask what type of formulas they are.
Yes.
And accordingly we will tell you about the type of formulas. You may like to understand which is it, whether it is polymeric, whether it is peptide based, antioxidant based, or what it is.
Okay, so I guess since the workshop is hands-on, we need to get our hands there for demonstration, get our hands working and enough of presentation. So now I would like to ask you first thing, before we start demonstration, we are not going to prepare. Okay, so tell me, especially I'm doctors or the otherwise doctors must have never prepared the feed. But is there anybody in the dietitian who has never prepared the feed, but just, please come. Come. Good. Who else? For the practicing dietitian who have never prepared the feed, who have just given the order and they don't know the complexities of preparing the feed or what supplement, if we increase the scoop size in the limited water, whether it will pass through the tube or not. Two first, and then for next demonstration I'll call the other. So two of, I'll let you know how to do. So what we are going to do is we are going to prepare a standard formula. So as ma'am already spoke about the different kind of formulas, type of formulas, this is a standard supplement which is Hynex ST plus. This gives enough calorie and protein along with meeting the micronutrient requirement also. So I have two of us. Your name is?
Dr. Rishika.
Dr. Rishika, and the other one is? Who is coming? No, she's not. Anushka. So the standard dilution says 180 ml of water with 4 level scoop. Okay. So I'll need one person to measure 180 ml of water, put it in the flask, add 4 scoop of the powder and dilute it properly. I'll need the other one to take 180 ml of water but double the scoop size. Means instead of 4 we'll put 8 and we'll see how the thickness is, whether it will be passing through the tube or not, because this is a standard supplement. So there are written instruction on all the supplements about the dilution factor. Okay, so let's go. Please come ahead. Yes. Yeah, go ahead. So on the flask itself is written Hynix ST plus. This is the arrow. Yeah. Okay.
How much scoop, ma'am?
4 scoop. 4 level scoop. So there is a marking here that says Hynix ST plus. Okay. We'll have to hang it there. Yeah. So why are we doing this? Why are we using a standard supplement and making it into 2 different dilution? Because what we are trying to say here is that it might become a little more thicker and difficult to pass through the tube firstly. Secondly, if we are willing to give more calorie or more protein in the limited amount of water, this is not the right formula to give. There are specialized formula that could be given through which more calorie, more protein can be given in a very limited water. So this also what happens is when we are putting extra scoop just to increase the protein and calorie, and we don't know whether it is going properly to the patient or what is happening to the patient after having such feed, because this becomes hyperosmolar. The osmolality of the supplement does become higher, right? So shake it well, you have done.
Yes.
So we'll put it in the bag.
Yes.
ये रख ले नीचे. You have put how many
Yeah,
scoops?
8.
8.
Yeah.
Hang it. Just you don't have to put the entire.
Oh, okay.
Have
I'm
you-
sorry. I thought I have to put.
No, it's okay. So now as we can see she has used the shaker, but still I guess the supplement is not mixed properly. So it's like there on the bag, which can lead to wastage also and not the exact calorie protein getting delivered to patient. If it was somebody else and they have not shaken it even properly, this would have led to under delivery of the prescribed calorie protein. Yeah, you open that. You have to put it down, beta. So see, you have okay, no, this has a opener and closing. So you open this.
So it will release.
It
the
is,
f-
yeah,
feed
it
by
will
itself.
release the feed. Now this feed is going absolutely perfectly. The flow is perfect. Now we will do with this. We'll have to. Can we use another bag? Can we use another bag? उसको रहने दो, वो निकल जाएगा. We'll use another bag.
If you have any questions, just keep it aside. We will take it in smaller groups little later on.
So okay, we'll put your feed. Hey, you just put a little amount of it.
Okay.
Let's see if it is passing properly. But it is a little thicker in dilution, yeah? Can you make out? That's it, enough. That should pass. But the osmolality here increases, so it might have an adverse effect, or it could lead to indigestion in the patient. But yes, she is shaken it well, so it is passing through properly. But in case of any other supplement, if it is not shaken properly, or if the feed becomes too thick, it might clog the tube. Yeah, you understood?
Yes.
Okay. Can we also do the pump thing? Yeah. Leave it there, no?
Ma'am, so this type will be the first type one, which the
This is just an example. Okay, you can ask your questions later.
thank you.
ये कौन सा था? ये वाला? It's not properly mixed. So as you can see, the thickened one was not properly mixed also. Again, so it was starting to accumulate. Had we put a greater volume of feed here, it would have clogged the tube after some time, right? Because what happens when you're hanging it for a longer time, for say in a continuous feed, you are hanging it for 4 hours or 6 hours altogether, this the feed start to settle at the bottom. You have to continuously shake it, but in case if it is not mixed properly, it will start clogging the feed tube. Now Kajal will, oh yes, okay, sorry. So the second demonstration that we'll go ahead with, another supplement, like we did a standard, and we said we cannot, if we want to give more calorie protein, we can't use the same supplement in larger scoop size in the same dilution, in the same amount of water, but rather we have disease specific or condition specific. So for example, we have Frazubin HP. Now if you, it reads dialysis care. So it can also, it's not like it can be used only in dialysis care, but any patient who is on fluid restriction. So there is very minimal fluid that you have to work out the feed with, and also in case if the patient's electrolytes are haywire, you can use the supplement. So we'll just, one of you can come, yeah, please. So the dilution goes as 60 ml of water with 3 scoops of supplements, which is a good amount, gives good amount of calorie and protein, but the water required is very little. So here we were mixing like 4 scoop in 180 ml of water, we are mixing 3 scoops in 60 ml only, and we are giving higher calorie and higher protein. So you can use flask. So you have to measure 60 ml of water and put 3 scoops and see how the miscibility is, whether it is mixing properly or not. You can yeah. So this is a fairly big scoop. Yeah, the powder that we put was quite enough. I mean, it was good amount, and the water is very little. So the miscibility here is much better. The osmolarity doesn't change because this is the supplement designed for such feed where the volume of the water is very less. Okay, so this will easily pass through the tube. We are not putting it in the IV bag. Thank you. Your name is Shruti. Shruti, thank you.
The next we'll be seeing about the same formulas with different dilutions. Okay, this is also meant for patients with fluid restrictions and with larger calorie or protein requirements. Okay, one more person I would want to demonstrate. Think. Three of us, three of them.
You can come up. Yeah, definitely.
Yeah.
Or maybe maybe we'll do a demonstration of preparing it into 3 different ways where the doctors can do it, with spoon, with blender, and with a shaker.
Yeah, please.
Please come.
Start with this. one we will take 1 calorie per ml, that is around 6 to 7 scoop in 210 ml of water. Yes.
You can prepare simultaneously. Come on, take it.
Yeah. The other one, 8 scoop in same 210 ml of water. Six scoops.
So one will put 7 scoops in 210. The other will put
8 scoops.
7.5. 7.5.
Yes,
Same,
the
same.
same supplement,
In three
one
different
with
packets.
same amount of water, 210 ml water with 6 scoops, one with 210 ml water, 8 scoops, and another with the same 210 ml of water with 9 scoops.
We can explain what happens when you take separate dilutions. So that
9
or else
scoops, right?
let's
Yes.
ask what happens when you change the dilution.
Dilutions.
Kilocalorie per ml changes.
Yes, kilocalorie per ml changes. What else? Fluoride, yes, fluoride is another aspect which we'll look into it.
This is basically for with small amount of water, different calories per ml we are planning. Okay, so if you increase the scoop, yes, it is all mentioned in the product.
Would you like?
Yeah, that's why this specific formulation, these are the formulas that is used for patients with less fluid volume, but then you need different calories, you need higher calories and protein. Okay, standard formula, only one dilution, fixed amount of dilutions you can use. This is specific one.
This is not disease specific.
This
but
is
this
a
also gives you the freedom to prepare it into
different formulations.
different volumes.
Yes.
So we can't do that with standard. We can't do it with disease specific like I showed for
Renals.
supplement. We need to keep the water that much and the scoop as prescribed. But with this supplement, you can play with the scoop.
Usually this is semi-elemental.
Which is
Semi-elemental.
formula. Yes.
How to differentiate? What is the difference between elemental and semi-elemental?
I guess ma'am spoke about it pretty good.
Semi-elemental was like
Semi-elemental was pre-digested. That is this
Hydrolyzed forms of.
And monomeric is elemental is 3 amino acids.
so elemental is monomeric. Is it like
Yes,
that?
elemental is monomeric.
It might be monomeric, yeah, for yes, it kinds of monomeric only. It's not polymeric based. Yes.
Yeah.
This is usually used for with digestive compromise and all, but then you need more amount of nutrition to be
So
delivered.
if we see, look here.
See, this is with the 210 ml water, 6 scoops of it. That gives 1 calorie per ml.
Now here, how many scoops?
This is 8
8
scoops.
In 110 ml of water, the miscibility remains almost same. The feed is not too thick even after putting extra scoop there.
Okay.
So one mistake that is happening here that they are not shaking it properly. So if you see this way,
Yeah, if it is not properly mixed, there are lump formations there.
we have to understand that most of the powders are hygroscopic and their consistency will vary. Taking the first step, second important step is straining if possible.
This one with around 9 scoops in the same 210 ml of water.
So now what we commonly saw here while these girls were preparing, since they have been done it before, the powder was not mixed properly. So the third one is to demonstrate that only that what would be a possible proper or the right technique to prepare a feed. Yeah. So now I'll request 3 doctors to come over.
Thank you.
Please. Come on, sir.
Blender.
I want a
This glass, no?
So again, this is semi-elemental, right?
Yeah, this is semi-elemental.
Because in textbook it is mentioned semi-elemental, but on product it is not shown.
No,
No, no.
how you can see what it is depending on the content.
Content.
So if the protein is in the peptide form, the
That's what
amino
we
there,
showed it
yes.
earlier.
MCT is there or vegetable oil
That is
is there.
semi-elemental.
Yes, exactly.
And
Yeah,
elemental is again only
Basically, this normal as we eat, everything will be in a proper
elemental.
polymer.
Okay, okay.
Yes.
Okay, you'll have to come here.
The semi-element is partially
Hydrolyzed.
Okay, already partially alkaline.
Yes,
So
yes.
The,
When the gut is
digestion
compromised,
becomes
it's easy for us.
digestion becomes easy.
Easier.
We'll use the same formula now.
Yeah.
To save
Yes,
the
yes.
time, we'll just use the same formula.
So one of you
Just have a look.
will use a spoon and a glass. They'll have to glass के लिए वापस थोड़ा करना पड़ेगा.
One glass.
You can do with the
Let them
blender.
go
You'll have to
through.
hold it tight. Yeah.
You can use it. The
Glass.
glass.
Start.
Yes.
Just hold it up, please.
Yeah, you can. You can see it's very well blended.
I've added 3 scoops of the powder here, and I'm giving you water. What you have to do is you have to prepare it in a way that it will pass
through the tube.
easily. And the third one will do it with the shaker.
Yes. This one you can use.
Yeah, if that
Yeah,
is-
you can do it from this.
You put this. आप दूसरा दे दो.
Same. नहीं, दूसरा ही है. He'll add. Okay. You can use it with shaker. You can put it in this and then shake it. Yeah.
Here.
The supplement. 3 scoops.
See, when you're taking the scoop also, that also matters.
But
It should be
it should be a leveled scoop, not the heaped scoops.
So when the nurses are doing the feeds, that also means like you have to train them properly.
So every scoop has different measurements.
Measurements.
So general standard instructions, what we find is like 2 scoops,
Yeah.
TDS. So if you talk
Okay.
about 2 scoops, what is the scoop size?
Shake.
Whether it is 7.5, 12.5, 10 grams, it will vary. Ideally, the feeds are designed in such a way that when the feed is prepared, they will give 1 calorie per ml. So if you are planning 200 ml, you should understand that they are giving you around that much of calories up. So
I think the
depend-
time is up. Sorry.
Yeah.
Okay. Otherwise, I'll keep shaking it.
So if you
Okay.
have 200 calories, that means around 200 ml. But the best part is what they had said, in different types of products, you also have feeds which are 2 calorie per ml. So this will be an advantage in patients where you have a little lesser volume to be given and more calories to be derived.
So coming back to Sita.
Yeah.
You show.
So this is the one prepared with the shaker, hand shaker. Look at the consistency, it's well blended. There is no lump also formed. Okay.
So done in a right way, even through a shaker,
Shaker
it could pass easily. It can
and
even easily. The second one is,
and this is through blending with a spoon.
you can see the powder on the spoon
Okay.
itself.
It takes longer time also, and there are still lumps formed. And this will end up in product wastage also and tube clogging also.
And
Okay.
why is it important? Because our patients get discharged, and when they get discharged, we guide, we make a plan, but we really don't know what they're doing at home. So we should have, apart from the chart, we should have the instruction sheet. What should be the position of the patient, the angle, then how is the feed has to be prepared under home conditions, and what are his facilities available with him. Sometimes there are caretaker, or sometimes there are family members. So that guidance is very important.
So the reason for us to call you and you guys and make you do is to understand the practicalities of preparing a feed. It's not only about writing on a paper and giving it to the ward or to the sister to prepare or to the relative at the time of discharge, but you should be knowing that what is the right way
Right.
to prepare the feed. Thank you so much.
In ideal scenario, that is why the most of the training is contributed and is given by the dietitian to the nurses team, because they most of the places nurses are the people who will make feeds at the bedside.
So now we'll move on to, we have seen different types of products. And now we'll move on to different techniques of administration of the feeds. Okay, it might be bolus, giving, it is used through usually syringe or even through the bag it can be given, but then one, like what we eat, like how we eat, one meal a day, it is given at a stretch. Okay, larger volumes at minimum of around 200 ml at a stretch. It can be given every 2 hourly, 3 hourly based on the instructions given by the doctor. That is called as bolus feeding. And the next one is intermittent feeding, that is given through the bag, even or through the syringe also, through that goes through pump or the gravity. Okay, it is around 4 to 6 feet divided doses per you are giving the feed, and it will take around one feed 20 to 60 minutes that you can give. The volume will be around 100 to 150 ml per hour can be fed to the patients, and it can be increased depending upon the fluid requirements of the patients. That is called as intermittent feeding. And continuous, the next one is the continuous feeding, which is most preferred especially in the critical care areas. Okay, this is over 24 hours assisted by the pump. Okay, pump settings are all there. The volumes like around starting minimum of around 20 to maximum of around 100 plus volume can be given through the pump assisted. Okay, that will be through the pump. So manually the time and this thing will be saved, and then we can ensure proper delivery is there. Okay. Yeah.
So we will be showing you the pump setting at the end. Because then there is no gap against the
Okay, as said, the osmolality of the products will differ. Okay, osmolality is also important because different osmolar, like we said, higher calorie feeds in small volumes we can give, but they'll have higher osmolality. For them to tolerate it, the patient must ideally tolerate it. They have proper gut functioning for them to tolerate. So osmolality is important. We'll have sometimes if they may not tolerate, you will have to go back check the osmolality of the product. So accordingly we can change it. Okay, ma'am, next. Okay. Okay, how do you choose different formulas for different patients? Is first, as said, first assess the patient for the need of enteral nutrition. Assessment only will have to include their history. Okay, wherein we take their nutritional status, any weight loss or something like that, disease related to disease, was there any issues with the functional gut or not, any digestive issues are there. Okay, so accordingly we can plan. If yes, chain next. Okay, enteral nutrition, as said, it is advantageous. We are, as the gut is functional, use it. Okay, but then if it is not administered properly, it is not taken care of properly, there are some pitfalls and complications that might occur, which may be serious also at the end. So this can include clinical complications like gastrointestinal, mechanical and metabolic complications, and safety related complications like pulmonary aspiration, enteral misconnections and all that. We'll go in detail in the next slide. Like gastrointestinal, sometimes diarrhea, nausea, vomiting, or constipation may occur. What I'll ask you, what if the patient ends up in diarrhea? Will we stop the feed or should we continue the feed? Not really. Okay, diarrhea may not be always because of the feed. Okay, first we must know, we must understand exactly the reason of diarrhea, because patients will be in so much of antibiotics and medical therapy going on, their gut will be compromised. Okay, so first we will have to analyze what are all the reasons for it. We have to rectify that, and then only end up, if it is feed related, then we will have to change it. Not necessary, diarrhea hai, immediately it is not necessary to stop the feed. Okay, if it is, we use fiber, especially guidelines says fiber using for C. difficile related diarrhea. Okay, they will check diarrhea, we can shift, if they may not tolerating, you can shift from standard formula to a semi-elemental formula first. If then still the diarrhea persists, you can add in fiber supplementations to that. Okay, and nausea and vomiting, sometimes the same way. All these complications, if that happens, you need not abruptly stop. First, we'll have to find the source, why it is happening. Some drugs may cause diarrhea. Sometimes drugs may induce abdomen distension and vomiting. So first, change the drugs and this thing, and then we will have to modify the feeds only if needed, or else you can continue the same. Okay. Then coming to the metabolic complication, one of the most important is refeeding syndrome. If you find the patient is malnourished, always start with the smaller volumes of, don't directly start the target calorie protein immediately, go slowly. Okay. Next, related to safety related complications will be pulmonary aspirations and enteral misconnection. Aspiration risk can be prevented, okay, by head and elevation, following few techniques like head of the bed elevation and then giving prokinetics. If still patient at risk of aspiration, you can always go nasojejunal feeding, okay. And then enteral misconnections, sometimes patients long term feeding pe hai, there are chances of tubes getting dislodged, okay. So then we will always have to see, regular monitoring is most important. Yes, okay.
We'll see the
Demonstration of the pump.
Infusion pump or feeding pump. Kajal will demonstrate what is the right way of using or keep speaking the feeding pump.
Good evening everyone, this is Kajal from Fresenius Kabi. Just today I am going to demonstrate the Amica feeding pump. Amica is the feeding pump which delivers the feed in a continuous method. It is a volumetric pump which is delivered in a peristaltic movement. मतलब जो भी feed है, it is delivered in a form of a wave. It is a ambulatory. It has a 360-degree clamp. So it can be moved like this, and it is generally attached bedside of the IV stand, and whenever patient goes to dialysis for a chemo, you can easily free mobile for that. And main function.
While she is setting,
Okay. Okay.
but this is something which is more requirement in the critical setup. Continuous allows the feed to be delivered slowly.
मैम ये निकाल दो, बैटरी डेड है उसका.
You can hear all these beeps. These beeps is to kind of caution you.
Okay.
Why is it showing a beep?
Okay. So here we can see the on the display. Here is the volume, मतलब total amount of feed you put it in the bag, 100 ml or what else जो भी आपको दिया जाएगा. And here is the 60 ml, मतलब targeted, मतलब how much feed you have to deliver in a particular time, मतलब flow rate is there. So you have to set here a total volume you have to deliver to patient and flow rate of the feed. So you can deliver it 1 ml per hour to 600 ml per hour to your patient. Okay, I'll demonstrate. This can be 1 minute. वो बंद कर दो, अलार्म देता जाएगा. 3 seconds. Okay, you have to press this on button for a 3 seconds and it will get start. Then next one, you have to align this tube. This one is a purple colored clamp designed for a patented for this pump only. It goes with this bag only. So you have to push like this, align the bag and close the door. Okay, and we have done priming. Here you can do the automatically priming through this button, but we have done manually. So 200 ml is the total feed.
So
Okay.
there is one is target volume. I mean, first is target rate, that is ml per hour will be there, and another option will be a target volume, like per hour how much feed has to go, you can set in, and total in a day how much has to be delivered to the patient, that can be set up. Okay, starting usually we say 24 hour of feeding starting. So when you first pour the food, do these settings and keep, and then when you start the tube, automatically there will be a demarcation या फिर indicator where it will automatically show how much the feed has been delivered in a day. So it's very easy to handle. So target rate and volume is there, and you can check how much volume has already been got. Okay, and
So here we are going to start the feed. Here are the three droplets, which means ki feed is going to your patient. Then here are the menu button. So you can show the you can see the 250 last episodes. How much feed मतलब 250 last feed आप देख सकते हो कि कितना ml गया. How much is delivered to your patient, and you can set it on a night mode, so it will save the your battery. Automatically LED का जो भी brightness रहता है वो कम हो जाता है. Okay, and unique मतलब सबसे अच्छा point क्या है कि it will alarm whenever occlusion is there. मतलब यहाँ पे कुछ error आया, occlusion create किया, upper stream है, lower stream है, it will alarm you and show on this monitor battery is about to end, feed is about to end. Here is the one progress bar. Sir, you can see this na last one वाला square. तो यहाँ पे you can see the progress bar. मतलब अगर तो हम लोगों ने 200 दिया है, यहाँ पे target set क्या है, 100 is delivered, तो यहाँ पे half is done. Okay, यहाँ पे show हो जाएगा, and I'll create one occlusion. Okay, and another one is that ma'am said that कि
another one, there is an opportunity of how do you give the medications when the patient is on RT feeding? How do you give medications? Tube, yeah, it's through the tube, but how? Will you mix it with the tube? I mean, mix it with a feed, or how is it? No. Okay. So usually when it is another type of bags and all that, you will have to stop the feed for a while, crush it. Preferably use a liquid one, okay, but then you will have to crush the medication and push it in a separate this thing. So we have in this pump separate port wherein you can stop the feed for a while, then give the medication. And one more important thing is, before and after giving medications, we will have to flush it. Okay, what happens is, if we forget on a long run, if the patient is on tube feeding, it might clog. Tip में clog हो सकता है, then you may not know. That will end up in long-term complications.
Continuous means we give 24 hours or we give a break for 4 hours in night?
as per
That depends. That's
You can give a
institutional
break
policy.
because in our hospital we keep
We do
20
give a
hours.
break.
Initially we had a 24-hour protocol, but we have kept a 20 hours
At night,
continuous.
4 hours we stop.
Yeah.
सर here we created one occlusion. तो यहाँ पे शो हो रहा है कि डाउनस्ट्रीम में कुछ तो अटका है, तो अभी occlusion आ गया, तो what to do? We have to stop this, we have to clear that occlusion ना, तो we have to press stop, ये निकाला, then restart.
We can give with the normal infusion pump also, like
No, no.
That is not for feeding.
Infusion.
There also it is ml per hour it shows, means like
That is for smaller amount of liquids, not for like 400 ml. It can be up to
50
maximum.
cc syringe we can use there.
But how many
Yes,
times are you going to fill that
saturated
50 cc again and again?
Clear.
That if you look at the osmolarity, there are so many different. Yeah.